Hi there, and welcome back to this second section on the management of tachyarrhythmias and the drugs that we use. In this section, we'll be particularly focusing on the side effects and adverse reactions from these drugs. The side effects of antiarrhythmic drugs are largely predictable. The mechanisms of action are generally pretty well understood. We know what they do, and that produces both generic and specific side effects. The generic ones are very easy to recognize. Clearly, in managing a fast heart rate, there is always going to be the risk that the drugs will produce an excessive bradycardia or negative chronotropy. Similarly, through mechanisms like vasodilatation and negative inotropy, we may also reduce the heart's contractility and produce hypotension, and things like falls and blackouts can happen. And a rather paradoxical statement is that all antiarrhythmic drugs have the potential to produce arrhythmias themselves. Similarly, there are going to be other specific side effects based on the mechanism of action, be it through the sympathetic nervous system, etc., and also a number of idiosyncratic reactions as well. Let's talk about pro-arrhythmic potential of these drugs, which, as I say, sounds rather paradoxical. This is going to be particularly the case in patients who are already quite sick, those with poor perfusion states, electrolyte abnormalities, and things like ischemia. So how does this happen? Well, if we administer an antiarrhythmic drug, we're expecting it to depress conduction. And one of the potential side effects of that is that it may make it possible for reentrant tachycardias to start. You'll remember from the first part, this is where a circuit, perhaps around an area of fibrosis, fires off repeated heartbeats to the rest of the myocardium. And sometimes by slowing the heart rate down and slowing conduction, these things can actually happen more spontaneously. Similarly, if we slow the action potential down and prolong the QT interval, then we may get early or late depolarizations. And as we said in the first part, this can provoke ventricular arrhythmias like torsades de pointe. The next point to say is about the additive effects of multiple antiarrhythmic drugs. All of these can cause side effects on their own, but when we start adding in more than one drug, then the problems become compounded. From your point of view, it's true for all drugs, but there's one combination I'll particularly mention, and that is mixing beta blockade with the rate-limiting calcium channel blockers. This can cause quite marked bradycardia. It can be quite negatively inotropic, can precipitate heart failure, or even cause heart block. So from your point of view, it's important to recognize that these two families of drugs don't mix at the same time, and a period of washout is required before you move from one to the other. So moving on to some specific drugs, we can use adenosine to diagnose and occasionally treat arrhythmias. And predictably, when we administer adenosine, we would expect to block the AV node, and that might produce a rather uncomfortable and unsettling period of asystole. This can be very unsettling for you, and it's particularly nerve-wracking for the patients. As you can see from this trace, usually after a matter of seconds, the adenosine is metabolized and the heart rate is restored. But it can be quite unpleasant to have adenosine administered to you. Regarding adenosine, it's very important to warn your patients of the effects before you give this intravenous dose. You can tell them that things will only last for a few seconds, and for that reason it's also important to administer adenosine through a proximal cannula. You should warn them about facial flushing, chest pains, dizziness, and often described as an impending sense of doom, as well as this period of bradycardia or asystole that can sometimes even provoke a short blackout. The next thing to say about adenosine is what to do about patients with asthma. We certainly need to use it more cautiously in patients who have airways disease, and in particular those who are on theophylline, because the effects of adenosine will be longer and more protracted if you're on a theophylline. So it's very important to warn patients of these side effects. Amiodarone, as I said before, is not something you will use a lot of outside of cardiac arrest for VF and pulsus VT. But it is worth being aware of the side effects, because you will see patients who've been on it for many, many months or even years, and there are some acute side effects as well. The obvious generic ones include bradycardia and hypotension, but as you can see from this picture here, it's important to also recognise that if amiodarone leaks from a cannula, if it's badly placed or it's dislodged, you can have a really unpleasant extravasation injury. You can see the tissue damage that's happened here. Some of the longer term side effects are also quite disabling and actually quite dangerous, as well as rashes and what's called a slate grey pigmentation. Because amiodarone dissolves in everything, it can affect multiple organs quite badly. For instance, you can have liver dysfunction, which can even be cirrhosis, thyroid abnormalities, both thyrotoxicosis and hypothyroidism, and as you can see from the picture here, lung fibrosis, or even during acute use, a pneumonitis. The final point to say about amiodarone is it's also got a lot of drug interactions. It doesn't sit well with warfarin, and because, like digoxin, it has a very large volume of distribution, it has a relatively slow onset of action. It takes a long time to build up in the body, and similarly its kinetics are poor, so when you stop it, it's going to last in the body for many, many weeks thereafter. Beta blockers are more straightforward and again more predictable in terms of their side effects. Of course, they can cause bradycardia and hypotension. We've already discussed that they can worsen airways disease, and commonly patients may describe having cold peripheries or even things like Raynaud's phenomenon. And like most cardiac drugs, it's worth mentioning to male patients that impotence can occur as well. On that sort of second to last point, we've talked about in the last section that airways disease will be particularly affected by the non-cardioselective beta blockers, such as propranolol and carvedilol. So if there is a concern about airways disease, you're better off, if you can, sticking to the cardioselective beta blockers in the blue box at the bottom of this. Calcium channel blockers are generally very well tolerated, and the only kind of practical points that are pretty common are things like constipation, flushing, and occasionally dizziness. And a lot of patients will notice a degree of leg swelling or edema. Because the rate-limiting calcium channel blockers affect the heart more, it's also important to consider whether they may worsen heart failure. But overall, calcium channel blockers are really quite well tolerated by patients, and they have very few side effects. There's one point to say there, however, and that's that whilst at therapeutic doses, these are not drugs that tend to cause a lot of significant side effects. Taken in overdose, they can be a real, patients can be extremely ill with hypotension. And when you see patients who've taken calcium channel blockers, it's easy to be deceived by their relatively benign side effect profile at therapeutic doses. What about digoxin? Well, digoxin has the predictable side effects of bradycardias and tachyarrhythmias. Interestingly, and we'll come back to this on the next slide, you may even notice that the ECG looks abnormal in patients with digoxin therapy. But it is wise to be aware about digoxin toxicity. We can measure the levels of digoxin in the blood, and patients who get toxic levels often start to feel they've got nausea and vomiting. Classically, they have something called xanthopsia, which is a yellow-green discoloration to the vision, although that's rare. Low potassium can increase the toxicity as well, and because it's renally excreted, patients who develop either an acute kidney injury or chronic kidney disease may become digitoxic. A practical point is that the way to get rid of excess digoxin can sometimes include dialysis and an antibody called Digibind, which is used in overdoses. I mentioned in the last slide that digoxin can affect the ECG. This is not necessarily reflective of toxicity. It can just happen as a natural result of being on digoxin. And typically it's called the reverse tick effect. And if you look over, usually in the anterolateral leads, and by that I mean V4, V5, V6, and 1 in AVL, you may see this reverse tick effect. It's often similar to what you might encounter with left ventricular hypertrophy, and that often coexists in these patients as well. But this is not a sign necessarily that the patient is toxic. It's just a sign that they are on this drug. So that's a quick summary of the generic and the specific side effects of antiarrhythmics. And that brings us to the end of this series of talks on tachyarrhythmia. In the next talk, I will talk about the management of bradycardias. Thank you very much.